Yes, sir. Proceed.
My screen is visible?
Yes, sir. You can start the program, sir.
Should we start now?
Yeah, sir. You can, sir. Yes. Proceed, sir.
Yeah. Dr. Badial, sir, you can start.
Yeah, sir. Already it is in live, sir. You can start.
Dr. Badial, sir?
Hello. Good afternoon, everyone.
Yes.
Good afternoon, everyone. As we get together for the deliberations on today's sessions, my best wishes to all the speakers and the entire team so that we get benefited from this series on CBME, the series 3. Thank you so much.
I would like to invite Dr. Padamja Uday Kumar to release the video of Napticon. Dr. Padamja Uday Kumar.
Yes. Good afternoon, everyone. Welcome everyone to this last of the webinar series. There is nothing much for me to say. You know, the great speakers. We are all waiting to listen to both of them. All the best to the speakers. Thank you. Yes, hope to see each and every one of you in the conference. All preparations for the conference going on in full swing. Thank you.
Thank you, madam. Thank you very much. Am I audible, Dr. Kamal?
Yes, sir, you are audible.
Good afternoon, everyone, and welcome to this fourth and the concluding session of the CBME Series 3 workshop in pharmacology that we have been carrying on for the past 3 weeks. And we have had very, very useful deliberations for the past 3 weeks. And today we conclude by having two very, very important topics. One is going to be on linker cases in pharmacology, alignment and integration. And the other one is going to be on feedback in pharmacology teaching, tips to give effective feedback. To moderate both these sessions, we have two very eminent members of our fraternity, Dr. M Jayanthi and Dr. Pinaki Chakravarti. Let me just take a second to introduce first Dr. M Jayanthi. Dr. Jayanthi ma'am, as you know, she is currently the professor and head of the Department of Pharmacology at JIPMER, Pondicherry. She has a wide experience of more than 15 years. She is very keenly into medical education also. She has done her LTTC course. And she is also a resource person for the ICMR online prescribing skills course that has recently been rolled out for the interns, the Indian medical graduates. She is the member secretary of the IEC at JIPMER Pondicherry. She is not only a teacher for the MBBS, but MD, and she is also a guide for PhD students. Her keen interests are in the fields of rational use of medicines, pharmacogenomics, research methodology, and clinical trials. She is also a resource person for these workshops, which are famously held in JIPMER Pondicherry, very, very popular workshops on bioethics, research methodology, clinical trials, and pharmacogenomics. I thank you, ma'am, and thank you for accepting our invitation. Let me now introduce the second moderator, Dr. Pinaki Chakravarti. Dr. Chakravarti is the professor and head of the Department of Pharmacology at Tejpur Medical College, Assam. He is a CPC SE nominee and also an NMC assessor and a core committee member of the Pharmacovigilance Program of India. He has got a keen interest in ethics and is the member of the ethics committee and very keenly interested in medical education unit also. And he is the teacher and president of Northeast Medical Pharmacologists Society. Thank you, sir. Thank you very much for accepting our invitation to moderate the sessions. So now I just call upon Dr. M Jayanthi madam to please start the proceedings and introduce the first speaker.
Thank you, Dr. Sushil Kumar sir. It is my privilege to moderate this session, the CBME third series as part of this series program. So thank you very much for giving me this opportunity. So we all know that alignment of related topics to the extent feasible has been a major thrust of the competency-based curriculum, and integration of relevant topics facilitates not only a better understanding between the subjects and also their ultimate application to the patient. So in this regards, we have an important topic by Dr. Pooja Reddy, who is an eminent pharmacologist, who will be talking on linker cases in pharmacology teaching, alignment and integration. So I will introduce Madam to you all. So can I have these slides, sir? Okay. Dr. Pooja Reddy is currently professor and head of Department of Pharmacology at SAMC and PGI Indore with 13 years of teaching experience. Madam is a resource faculty at the medical education unit there and is a chairperson of Pharmacy and Therapeutics Committee. She is an exam superintendent of Sri Aurobindo University and a coordinator MDMC, MVPI, SAMC and PGI Indore. She has done advanced course in medical education and is currently pursuing PhD in medical education under Dr. Ved Prakash Mishra. Madam has organized the 13th annual conference of ISRPT in November 2021, and she has organized the 8th workshop of Indian Pharmacological Society on GCP NDCT 2019 come clinical research in June 2022. And she has multiple publications in national and international journals, and also a life member of several of the professional bodies. Now I request Dr. Pooja Reddy to give us the talk on linker cases in pharmacology teaching, alignment and integration. Madam, over to you.
Thank you so much, ma'am, for the wonderful introduction. I'll try to share my screen. Is my screen visible?
Yeah, ma'am. Presentation mode.
Very good afternoon, everyone. At the outset, I would like to record my gratefulness to the organizing team for giving me this opportunity to present amongst the stalwarts of pharmacology. So coming to the topic of today's discussion is linker cases in pharmacology teaching, alignment and integration. The objectives of my session will be, at the end of the session, the participants should be able to discuss linker as a method of teaching and apply this method in their teaching context. We all know the alignment and integration module that has been given by the Board of Governors, and it is available on our UG curriculum website of NMC. We have this module, alignment and integration, in which we have the mention of linker case. Although we must have attended many workshops on alignment and integration, linker cases have been less discussed here before. Before directly jumping to the linker case, I would just like to very briefly brush up the concepts of integration and alignment. Of course, we all must already be knowing that systematic organization of curriculum content and their paths into a meaningful pattern is nothing but integration. Why should we integrate? As quoted by Humphreys, it is taken for granted apparently that in time, the students will see for themselves how things fit together. Unfortunately, the reality of the situation is that they don't. If we teach connectedness and integration, they learn that. If we teach separation and discontinuity, that is what they learn. To suppose otherwise would be incongruous. So, coming to what is alignment, alignment is nothing but it implies the teaching of subject material that occurs under a particular organ system or the disease concept from the same phase in the same time frame, that is temporal. Integration is that the concepts in a topic organ system that are similar, overlapping or redundant, when they are merged into a single teaching session in which subject-based demarcations are removed. These blocks are then divided into teaching sessions. So we all know about the horizontal integration and the vertical integration. Integration as it relates to the GMR, as we all know, this is the temporal coordination, that is alignment, when the subjects are teaching the same topic, but in the same time frame. And this is the integration. We have many models of integration, such as Hardin's model and many more models. But the integration that we are sticking to in CBME, we have sharing, in which two teachers of two different subjects are sharing the concepts. Then we have correlation and the nesting. So nesting, we all know, which most of us are already doing since years. We have the concept of different subjects through which we introduce and we take, the single teacher is taking in the same class. In correlation, we use the linker cases. We can use linker cases in correlation. Correlation is nothing but the different subjects, even if they are teaching the concept in different time frame, they relate it to a single case, some common case. It is nothing but linker. So linker cases, they can be used in correlation. How do we define linker? According to our module, linker is a session that allows the learner to link the concepts presented in an integrated topic. For example, I take some case, this is the linker, in which we have some concept of pharmacology in which we are teaching the pharmacotherapy. Then comes microbiology, where they are teaching lab test, virology, bacteriology. Forensic medicine are teaching the post-mortem findings of the same diagnosis of the same case. And the medicine people, they teach the symptoms, signs and management, maybe later, maybe in the third phase. So here lies the role of linker. A linker as defined above is a trigger that aptly links the various related standalone elements represented in an integrated topic, and it helps to correlate these. So in the medical curriculum, the linker is nothing but most commonly it can be a paper case, a video case, or a live case. A case that can be creatively written and can be used in each phase. So the case that I'm using in phase 2, the same case must have been used in case 1. The same case can be used in phase 3 and so on, to allow the students to correlate what they have learned and apply into understanding disease process, diagnosis, and care. We all must have gone through the steps in development of aligned and integrated topic. We all have made our own timetables of our institutes. Here again lies the role of the linker. So this slide, I won't go in detail. You people can go and revisit it again. So here again, the alignment and integration, the topics that can be aligned are aligned, some topics that can be integrated. And where the linker can be used, we can use a linker either in the same phase or the different phase. Again, this diagram has been taken from our module. So these are the 4 subjects, phase 1, phase 2, and phase 3. This purple colored is a linker. So this linker is usually a case with sufficient complexity from the same topic from a higher phase, which is used to anchor the learning. So even if the case seems to be more complex from phase 3 student, and if it appears complex in phase 2, still we take it and use it in phase 2 to give a holistic view to the student, either in phase 1 or in phase 2. Now coming to the linker cases in pharmacology, what I thought of these few topics, they are some common examples in which linker cases can be used. There can be many more, like anemia, hypertension, diabetes, tuberculosis, malaria, and PCOS. These are just few of which I could think of. Anemia, we have been studying in all the modules. So this time I chose the topic of tuberculosis, which we'll discuss in today's discussion. So this is my linker case. Mr. Janardhan, a 30-year-old male, presents to the medicine OPD of SAMES Hospital after 4 weeks of cough, profuse nocturnal sweating, loss of appetite, and hyposomnia, and was suspected to be a case of pulmonary tuberculosis. His vitals have been mentioned: temperature, pulse, respiratory rate, BP, and saturation on room air. Now taking this linker tuberculosis case, we have some subjects like microbiology, pharmacology, radiology, medicine, and respiratory medicine. And there can be many more subjects. I have taken these 4, which can contribute in diagnosis and management of this case. So first, let us see microbiology. This particular patient, Mr. Janardhan, he was advised to undergo microbiological evaluation for possibility of pulmonary tuberculosis. So blood culture, sputum smear, gram stain, acid fast stain, and sputum culture. These things will be taught in microbiology to the student using the same linker case. These are the findings. The competency that will be achieved in microbiology will be these few competencies. For example, I'll just read 1 or 2. Describe the different causative agent of infectious diseases, the method used in their detection, and discuss the role of microbes. Perform and identify the different causative agents of infectious diseases by gram stain, ZN, AF, acid fast bacilli, acid fast staining, etc. Now coming to pharmacology part. If we use the same linker case in pharmacology we can add that based on the findings, the patient was diagnosed to have pulmonary tuberculosis and was advised to initiate treatment as per the latest regime. In this pharmacology, we'll tell them about the national programs of tuberculosis. We'll tell them that previously the DOTS, which was called as DOTS, is now called as DOT, direct observation of treatment under supervision, has been removed. We teach them about the drugs, the intensive phase and the continuation phase, the first line drugs of tuberculosis. Then we tell them why the DOTS has now been replaced by DOTIS. Now when they take the pill, they have this code by which they give the missed call, and this is how the therapy is being observed by the DOTS people. Now we can also tell them about the fixed dose combinations of first line anti-tubercular drug. So the advantage is now the pill burden has been reduced. Initially, each of the first line drug dose was calculated and so many medicines the patient had to take. which has reduced the resistance generation also. It has improved the cost effectiveness and improved the compliance in dot therapy and all. Then we'll tell them about the side effects of tuberculosis. Of course, we'll also cover the pharmacotherapy of MDR and total drug resistance and drug resistance tuberculosis. Now, regarding this, you all know this NICSHE is one of the program taken up by Ministry of Health and Family Welfare, Government of India, in which we have these 3 phases of NICSHE. Now, if we have one competency, most of you must already be knowing, we have this competency PH 1.55, which says, describe and discuss the following national health programs, including tuberculosis. But the same national health programs are also being discussed by community medicine department. So if the community medicine department is going to teach this NICSHE part in detail, then we can just introduce this part, and we need to discuss and integrate with the department. And even if we are reinforcing the concept, we need not repeat it in detail. That would help us to save time and reduce the overlapping. The other competencies of pharmacology that can be achieved by this linker case will be PH 1.44, describe the first line anti-tubercular drugs, their mechanism of action, side effects and doses. In PH 1.45, we describe the drugs used in MDR and XDR tuberculosis and so on. So after studying microbiology and pharmacology in phase 2, when the student enters phase 3, in radiology, the same linker case can be used, and then again the case can be written as he was advised to undergo radiological evaluation for possibility of pulmonary tuberculosis, so chest X-ray. This competency will be achieved in radiology. So similarly, again going back to medicine and respiratory medicine, we have some competencies of medicine again, in which they have all the diagnostic tests based on clinical presentations. In respiratory medicine, they have long list of competencies regarding this tuberculosis, in which these 2 I found was exactly what we are already teaching in phase 2. One of them is describe and discuss the pharmacology of various anti-tuberculous agents, their indication, contraindication, interactions, and prescribe an appropriate anti-tuberculosis regimen based on the guidelines, which is including the DOT regimen. So these 2 competencies, which are already achieved in pharmacology, can just be nested by the respiratory medicine. They can just reinforce it in very brief and need not teach them in detail. I hope you have got the concept of how we use the linker case and how we can make many more cases, and the same case can be used in each phase so that the students remember and the concepts get reinforced. What should be the steps in using a linker case? First and foremost, identify a list of topics or organ systems that will be accommodated in the timetable as aligned and integrated topics. Get learning objectives for the competencies to be covered. Then see what can be shared, correlated or nested. Then take our learning objectives where correlation can be done. It might be as less as 5 to 10% only. Then design a linker case. Use the linker case in teaching as well as in assessment. So like if we follow these steps, we can have linker cases. How can we actually put linker case to work? First and foremost, get leadership buy-in. Because if the faculty who's taking the initiative to design the linker case, and if the other colleagues, team members, or the other department faculties are not following it, it will be losing its purpose. Get all the stakeholders together, and the stakeholders should not do it as a favor on anybody or just for the sake of completing or doing it. They should actually own the process, and then we can create many effective linkers. What can be the advantages of linker case? They can avoid redundancy. So when we are taking some clinical case, of course, we avoid discussing the redundant topics, and we discuss only which is very, very clinically relevant. It promotes contextual learning. The student will get the entire context, even if the case looks complex in phase 1 and phase 2. Gradually, the student will get the holistic picture. Use of linker allows students to safely apply knowledge to real situations. As the situations, as the case that we'll make will be realistic, and the students will apply their knowledge without harming any patient. Stimulates thinking and decision making. And for preparing a linker case, of course, minimal equipments are necessary. So it's very easy and feasible also. Group work stimulates discussion and teamwork. Remember, you don't have to do it all at once. So if I'm using this linker case in pharmacology, I need not over teach them about the investigations, the diagnosis, symptoms, and everything. Of course, I can discuss it in very, very brief, but do not try to teach everything in single subject. When you begin, you must be committed. What are the uses of linker case? Using a case-based discussion in integrated blocks in small groups will in addition encourage collaborative and self-directed learning. So these case-based discussions can also be used for self-directed learning in small groups. Using the case discussion at different time points will allow the students to reinforce and link their concepts. There can be some errors in our linkers if they are too easy, if they are improperly sequenced. Sometimes we can make it too complex for the MBBS level students, which will make it impossible for them to solve. And if we are taking very fringe topics, so we have to be very intellectually designing the linker based case. We have to do it in a teamwork. There will be, of course, some asymmetry. As we saw in this particular case, before diagnosing, before taking the history, before taking the vitals, we are teaching management, that is pharmacotherapy in phase 2. Sorry. So after teaching the pharmacotherapy, the students will be the learning investigations and the differential diagnosis, history taking and all. So do we need to go in order? No, it's not that mandatory. Of course, there will be asymmetry when linker cases especially are involved. There will be varied levels of asymmetry. It may require some re-evaluation of our teaching schedules, and our attitude and our commitment towards delivering the effectiveness of linker cases is important. I hope you all must have understood the outline of the linker cases and how we can use it in pharmacology. We all must have understood it, and if not, I'll just try to explain it very simply in next 2 slides. This is the traditional case-based learning in which this was also the same diagnosis, and in the second part also the diagnosis was same, but they were not related to each other. Although both of them individually were very interesting, but if we cannot link it with one another. And this is an example of linker case in which first we saw, then the second part which was related to the first part, and the similar asymmetry of medical education can be seen in this case also. As Katappa ne Bahubali ko kyun mara, we came to know after watching the second part. So this is all from my side about the linker case. My sincere acknowledgements to Dr. Dinesh Badyal sir, who went through each and every line of my presentation and helped me. Dr. Sushil Sharma sir and Dr. Kamal sir, who have encouraged me and helped me in my presentation. Thanks a lot, and thank you all for all of your patient listening. Thanks a lot.
Thank you, madam. That was a very excellent explanation within this short time about linker cases, about the alignment and integration, and also you showed us an analogy also at the end with Bahubali and those questions. So it was really interesting. There are some questions in the chat box, madam. I think some of them you can answer. One I can read it, maybe one or two.
Yes, ma'am.
I think one was by Dr. Nirmala Rege. Is there a need to have a single linker case for a topic, or there can be 2 to 3 depending on the topic? This is the question, madam. Over to you.
So, according to my understanding, ma'am, we already are learning through case-based learning. In case-based learning, we have different cases on the same topic. For example, I am taking different case of hypertension in phase 2. Medicine faculty must be having different case. But the concept of linker is linking it to the same case. Of course, we can tweak it a bit according to our own subject speciality, but the concept of linker is if we are taking the same case again.
So can I, thank you, madam. One more question about, is it mandatory for faculties from other department to be present physically for integration? This is a question by Dr. Sanjeev Das.
No, not at all. As we all have studied that integration is to be done of the concept of the subject. Not integration is not to be done for the faculty. So physically present rehna is not at all important for the faculty. For example, in nesting, in correlation, in these sessions, we don't need physical presence of the faculty. In nesting is just I'm introducing some concept of microbiology or physiology in my own class. It can be delivered by a single teacher. But regarding planning, yes, all the departments whose competencies are achieved, they should plan together. But the delivery can be done by a single teacher.
Yes, ma'am.
I hope that's understood.
Yes, I hope that was clear. And sir, should we take up more questions, or madam can answer on chat box?
Yeah, madam, thank you very much. In fact, we have got a WhatsApp group with all the participants, and participants are free to put in their questions in that, and we'll be answering each and every one of them, madam, on that.
Okay, sir. So then, thank you very much, sir, for giving me this opportunity. Thank you.
Thank you so much. Thank you.
May now call upon Dr. Pinaki Chakravarti to please start the proceeding.
Yeah, good afternoon, everyone. And after this wonderful first session, now may I introduce our next speaker, Professor Sushil Sharma, who was in the Indian Army for the last 24 years, and he has done his MBBS and MD from Armed Forces Medical College. Dr. Sushil Sharma is very active with our organization, and also he has been interested in medical education. He completed his advanced course in medical education from the MCI Oral Center, Mumbai. He completed his NTTC course from JIPMER. He is a resource faculty at MCI Regional Center, and he has been an observer for the RBCW workshops. He published a very interesting book titled Drug Autobiographies in Pharmacology, and in fact, which is one of its kind and takes an innovative approach to teaching, learning, and pharmacology. He is presently our editor of the RX Factor, the newsletter of our National Association of Pharmacology and Therapeutics. He is a reviewer for many journals, Indian Journal of Pharmacology and the Journal of Pharmacology and Pharmacotherapeutics, Journal of Medical Academics, and many more. So he is currently the professor and head of the Department of Pharmacology and also the MU coordinator at AIMS Mangalapuri, Andhra Pradesh. And I welcome everyone to this, the last of the series. And feedback is very important in everybody's life. Even at home also, when my wife prepares something, she asks, how was the food? So that is what is feedback is all about. Feedback is central to medical education in promoting learning and ensuring meeting of standards. So feedback is essential in every field, and so is in pharmacology, so is in medical education. I welcome Dr. Sushil Sharma to deliver his talks. Thank you.
Thank you, sir. Thank you very much for the kind introduction. I will just share my slides.
Okay.
Are my slides visible, sir?
Yes, yes, yes.
Thank you, sir. Thank you very much. And welcome to the last and final session of the CBME Series 3 workshop being conducted by the National Association of Pharmacology and Therapeutics. And we would be talking about feedback in pharmacology teaching in my session today. And let me start by saying that I will not be covering the theoretical aspects of feedback. What are the different types of feedback? What are the pros and cons of feedback? But I will be restricting my talk essentially to the tips and strategies to give effective feedback. How can we make our feedback more effective? Do we have some tips? That is what I will be talking about in my presentation today. While preparing for the presentation, it was quite surprising for me to learn that in 1940s, it was the rocket engineers that first introduced the concept of feedback, where information was, when the rocket is fired, they feed continuous information into the system, and the system uses that information to make modifications and changes to the rocket trajectory. It continues in a dynamic way so that finally the rocket is able to reach its goal. Can we translate the same analogy to our setup, the medical education setup? We have got UG students in our setup, we have got PG students in our setup. They are also trying to reach their goal. They are also trying to become a medical graduate. So it is important that we also give information to them so that they can use that information and know what they are doing right, what they are not doing so well, and so that that information can be taken in and they can make adjustments to their learning, and finally they are also able to reach their goal. So that is the thing which I just wanted to connect. If you look at the definition, feedback is essentially a formative teaching strategy to present information on observed performance with the purpose of guiding the learner's future performance so that the students can remain on course in reaching their goals. So this is the definition of feedback. And I just want to bring to your attention this word, teaching strategy. Feedback is a teaching strategy. It is not about making judgments. It is not about evaluating the individual. It is not about putting the student under a microscope, saying that this is what that you are not good, or you are not doing, you are useless. That is not the aim. The aim is, it's a teaching strategy so that you can improve the student, you can improve the individual. So that is essentially the aim of feedback. Feedback has got a very, very important role in medical education. If the student knows this is what he is doing good and this is what he is not doing so good, so he can change. Feedback provides that impetus for change, and hence it is essential in keeping the students on course in reaching their goal. I like this quote I read somewhere. It says, if we are not giving feedback, we are not teaching. We are asking our students to read our minds. So that is the importance of feedback. In his seminal article in 2013, Harden presented, he said, be fair to students. 4 principles that lead to more effective learning. And what are the 4 principles which lead to effective learning? Number 1 is feedback. F stands for feedback. Of course, A is for active learning, I is for individualizing the learning, and R is for making learning more relevant. So if you see the 4 principles, number 1 is feedback. Feedback has got that much important role in learning. And it has got a critical influence in student learning. Despite robust literature showing the importance of feedback, it is very, very clear that feedback is not given so frequently. Studies have shown that when you talk to the students, they report that feedback is not given to them quite frequently. And even if it is given, that feedback is not effective. On the other hand, teachers believe that they are providing adequate feedback and they are providing frequent feedback. So obviously there seems to be a great gap between what teachers feel and what students feel about feedback. So what exactly, why the feedback is not becoming effective? What are the barriers? One of the most important barrier is that the purpose of the feedback may not be clear to the teacher or the learner. What is the importance of feedback? Why we should give feedback? That purpose may not be very clear. Secondly, there may not be any appropriate time or place for a feedback session. Feedback is a very formal event. You cannot give feedback while walking in the corridor or just talking to a student for 2 minutes. You have to have time. And many times that particular time or place for a feedback session is not available. Thirdly, most of us may not have formal training in giving effective feedback. And even if we have some training, it may be very, very minimum. So what happens is, even when we give feedback, that feedback could be very general. We just say, okay, yeah, you're doing fine, or you're not doing very well. That feedback is very general and is not so much helpful to the students. Somebody is calling me up. Is my audio clear to everyone?
Yes, yes.
Yeah, fine. Okay. So if teachers don't have training, they could just give very, very general feedback. Yeah, this is something, the hierarchical culture of medicine. This is something which all of us know. The medicine which is practiced as of now is very, very hierarchical, where the teacher is a sage on the stage and he gives sermons, he gives lectures to the students. And most of the times it is just a one-way conversation where the teacher is just telling and the student is supposed to just listen. So what happens is, slowly, this boils down to the teacher just finding faults, just telling the student why you're not doing this, or what is wrong with you, or you are doing this mistake. So over a period of time, what happens is the learner starts to view feedback as a negative experience. And the moment he hears about feedback, he feels that his performance is going to be criticized, and that feedback becomes ineffective. So these are certain barriers to feedback. So how can we overcome these barriers? Are there any tips and strategies by which we can improve our feedback? Yes, of course, there are a few tips. Tip number one, establish a safe and respectful learning environment. I cannot stress the importance of this aspect. A safe learning climate is the bedrock for delivering effective feedback. You cannot deliver effective feedback if the environment is not safe. Now, what is safe environment? A safe environment is where the student does not feel humiliated. He does not feel threatened. If you tell a PD student that, okay, you mount your tissue, I'm going to come and see and give you feedback. He should not be scared that, now he's going to go in for a humiliating session. So that atmosphere of mutual trust and respect is absolutely essential. It should be realized that teachers and learners are partners in the process of feedback. So the aim is to improve the student, and both teacher and learner are working towards that particular goal. And feedback session has to be two-way. Only then it can be a safe environment. If the student feels that I will also get a chance to speak, then he gets more confidence and he becomes more involved in the process. Feedback given with a considerate tone, gently and supportively, has been proven to be most effective. So even though this is tip number one, this is the foundation on which all other tips will be there. You have to have a safe and respectful environment where the student does not feel threatened, humiliated, or scared. Tip number two, communicate goals and objectives for feedback in advance. You just can't call a student out of the blue and say, come on, let me just tell you about your seminar skills or your journal club presenting skills. No, it has to be planned in advance. You must tell the student, okay, we'll speak next week on Wednesday, please come to my office. We will just discuss your seminar presentation skills. We will just talk about how you make your PPTs. So you have to tell the student in advance and schedule the meeting at a convenient time and quiet location. Try and keep 15-20 minutes separately for it so that you don't get disturbed. This actually sets the stage, making the learner more comfortable. He will be more participative in the feedback process because he knows beforehand that, okay, day after tomorrow, I'm going to have a feedback session and I will be told a few things which I need to improve. Tip number three, base feedback on direct observation. Students must perceive feedback as credible. If the feedback is not credible, they will not take it well. And now, what is credible feedback? Credible feedback is something which is well informed. You have to see for yourself before you call your resident and say, this is what you are doing wrong, please correct it. If you're not seen it an account, there is a possibility that you may not have the correct information and the feedback may not be taken well. I agree. Every time the HOD or somebody may not have the first-hand information, but he should try to get as accurate information as possible before he gives feedback to the student. This was a survey done by Bing Yu et al. They surveyed medicine residents on history-taking skills, counseling skills, various other skills. They found that if the feedback was not first-hand, they rejected it. They did not take it well if the person who was giving feedback did not actually see on his own. Tip number 4, make feedback timely and regular. Timing of the feedback is of utmost importance and has a strong influence on the effectiveness of the feedback. If you find that there is something which needs to be corrected, the teacher should provide feedback as soon as possible after the encounter. For example, if the student has done a bioessay, so what is important is the feedback should be given as soon as possible, maybe the next day. What happens is when you give it immediately, the feedback ensures that the context is fresh and clear in the mind, and the feedback is more effective. Even if you want to give corrective feedback, it is not correct to call the student and say, I have last month you have done this, or last week you have done this. No, it is important that feedback is as soon as possible after that particular event. Tip number 5, how do we begin the feedback? Begin the feedback by learners' self-assessment. It is proven in the literature that feedback which is initiated by the learners was more effective than initiated by the teachers. What does this mean? It means that when you have a student, suppose if you have a PG student, so ask open-ended questions. Okay, how do you think your seminar went? He has completed a seminar. So instead of straight away talking about what was wrong in that seminar, you just ask the student on your own. How do you think it has gone? What are your thoughts on it? So what are the advantages? There is a possibility that the student himself will come out. He said, sir, I think my slides are not very good, or maybe it was too lengthy, or maybe the animation was not very good, or maybe I did not cover recent advances. So he will come on his own. And when that happens, you can actually say, yes, you are right. I think recent advances you should not have missed. So what is happening is he has already given his self-assessment, and you are building upon that self-assessment. So it can soften the perceptiveness of harshness. He will not feel so bad. Because why? Because he himself has brought it out. Many times what happens is the student may bring out certain aspects which even you have not thought. So you can build it up, those aspects also. So always allow the learner to start with self-assessment. This will also help the learner to develop into a reflective practitioner. Tip number 6, reinforce positive and provide suggestions to correct negatives. Many faculty feel that if somebody is doing a good job, there is no requirement to appreciate him because he knows it is good, that's why he is doing. No, appreciating the positive aspects will give confidence to the learner, and it will motivate him to continue with the good practices. And it is always a good idea to start your feedback with positive things. And when you start with your positive things, the learner is more receptive to the entire feedback, and he will also take the negative feedback or corrective feedback in a better fashion. This is something which I thought I will just share for a minute here. Pendleton's feedback is a very good template which we can all use in our sessions whenever we are giving feedback to any PG student or UG student. It's called ask, tell, ask, tell. Now, what is ask, tell, ask, tell? First, ask the student saying, okay, the seminar is there, done, or the practical has been done, or the counseling session has been done, or the communication skill has been done. You say, okay, how do you think you have done well? What do you think you have done well? So the student will say, I have not done anything well. No, please poke him. So no, you please tell me what you have done good. So you'll see, I think my tissue mounting was very good, or I was able to greet the patient nicely. So you first ask a positive thing. And when you get a positive thing, you tell, you say, yes, you are right. I think that is what you've done very well. I also noticed that you've done it very well. So you have told him that positive thing again. Now you again ask, what could you have done differently? Please see the language here. We are not saying, what did you do wrong? We're just saying, what could you have done differently? So there is nothing right or wrong. We are trying to do something in a different way, which is better. So the student might come out on his own saying, I think I should have done that differently, or I should have examined the patient in a much better fashion, or I should have checked for the understanding of the adverse effects in a better fashion. So he will come on his own what could have done differently. And then you tell, yes, I think you should have done differently. If you had done this like this, that would have been better. So ask, tell is a very, very simple template we can all use in our feedback. I'll just take 30 seconds on this feedback sandwich, because whenever you pick up anything on feedback sandwich will be there. Feedback sandwich is where the faculty gives a positive feedback and then gives a constructive criticism, followed by again a positive feedback. So if you have 240 positive feedback, so the student feels better, and in the middle you give him the corrective feedback, what he can improve. So it is seen that the student takes it in a much better fashion, rather than giving all 3 negative feedbacks. Just start and end with a positive feedback. That will help. It's called the feedback sandwich. Tip number 7, use specific neutral language to focus on performance. Use specific feedback. You cannot say that I have found that your PPTs are not good, or your animal handling is not good, or your bioassay is not good. So it is non-specific. If somebody says my bioassay is not good, I don't know what is not good. Is my mounting is not good? Is my dissection is not good? Is my liver is not good? I don't know what is not good. So be very, very specific, and feedback should be on the behavior and not personality. It's important to talk about the behavior. It's better not to say, you are very lazy, or you are uninterested. So that is a personality. So you give specific. If you feel that he's uninterested, you say, when such thing happened, then we found that you did not do this, rather than giving a sweeping statement as, you are uninterested, you are lazy, or you are not doing hard work. Be very, very specific and neutral. Tip number 8, confirm the learner's understanding and facilitate acceptance. There could be a lot of emotions. If you bring a lot of negative feedback, the student may feel emotionally disturbed. So it's important to understand that emotions and work accordingly. Tip number 9, conclude with an action plan. After the feedback is over, it is important that you discuss with the student and say, okay, so now what is the plan ahead? What can be done to put this feedback into action and do something so that the learner can improve further? So this action plan, no feedback should be stopped without an action plan. Action plan is a must with any feedback. You could set up a follow-up meeting. Okay, let's meet after 15 days. And when you have another seminar, then we will see this time how you do that conclusion or the animations. So let's have an action plan and conclude the feedback with that. Tip number 10. This is the last tip from my presentation. Reflect on your feedback skills. After the teacher has given feedback, it's important that the teacher reflects, talks to himself. How did I give feedback? What went well? What I should change the next time? Can I give my feedback in a better fashion next time? So that reflection is very important. Why? Because even if we have prepared for a feedback very nicely, many times feedback does not go well. The learner may become defensive, or he may not accept corrective feedback. He may come with excuse saying, this happened because the problem was there, or I did not do this because this happened. So he may come out with a lot of excuses. So it is important that you reflect so that next time you are able to tackle that situation better. Making reflection a part of every feedback will improve the teacher's skills in giving feedback also. A couple of food for thought here. Many of us display after the exam the marks. So is that feedback? We just display on the notice board. So student knows I have got these many marks in this section, these many marks in this section. Communication, I've got this much, or intramuscular administration, I've got these many marks. So is that sufficient feedback? No, it is not sufficient feedback. Displaying marks is just providing information. For information to become feedback, it has to be actionable. We have to tell them why they have got these marks less. So it is important that if the student has got so many marks, why he has got these many marks. So unless you provide that information to him, which he can act upon, then only it becomes feedback. So if you could have a session in your lecture hall where you talk about the last term's question and say, well, this is the question of 8 marks, and I was looking for this, I was looking for that. Many students who have not written this, I have given them 3 marks. If you write this, I give 4 marks. So if that sort of action session happens, then it becomes feedback. How much is the correct amount of feedback? Too much of feedback can reduce the effect of feedback. If you give too much feedback, the learner may become totally overwhelmed and the feedback may be ineffective. So we have to give better feedback and not more feedback. Last slide from my side. Can we give feedback to individuals or can we give to a group? There are a lot of pros and cons for both. If you give to a group, you call 10 people and give them feedback. So the student can receive a wide variety of feedback. So what you are telling to his friend, he will also listen and maybe he will improve. So that advantage he will have. While the cons are reduced control over content. So 10 people are getting feedback. So the feedback may be so much that it may go out of control. Or risk of negative emotional impact. Some people who are very, very sensitive may not like it very well if you are giving them feedback with their friends or 10 people or 5 people. Finally, it is not to say that group feedback should not be given. The teacher must decide which should be given depending upon the context. I conclude by saying that feedback serves to guide learning. It reinforces desirable actions. It identifies areas of improvement and promotes reflection. Effective feedback brings to light the gap between the current performance and the intended goal, so that the students know what is the gap between them and they can work to close that gap. However, feedback is a double-edged sword, and if it is not handled correctly, it can leave a learner bruised, demoralized, and with a shattered confidence. Ultimately, feedback is about communication. The key skills of feedback are to listen and ask, not just to tell and provide. I leave you all with this message of Mahatma Gandhi, who said, whatever your message is, give it with love. Otherwise, both the message and the messenger will be rejected. Thank you very much. And thank you for the opportunity.
Thank you. And we are exactly on time. It's 4 o'clock. And I love maintaining time. We have one question in the chat box, and I think we can take this. And the question is from Dr. Sudha. She asked that, sir, you have been teaching for quite a long time now, and considering the change in quality and quantity of MBBS students, what is your opinion on feedback one-to-one for undergraduates on a regular basis, keeping in mind the attitude of today's students? Is it actually possible one-on-one? And Dr. Nishant Thakuria has asked, isn't it necessary for the students to give feedback on the teacher's performance? So, Dr. Sharma, you answer the first one, I'll answer the second one.
Sure, sir. Sure, sir. So thank you, Dr. Sudha Madam, for that question. For UG's, with 125, 150 students, and some colleges 250 students also, one-to-one feedback may not be so much feasible. You could give one-to-one feedback to some special group of students who you feel actually do require feedback one-to-one. But otherwise, doing is we can sort of call the students in groups of maybe 10, 15, or 20, and we have certain points which most of the students need to work on. Those things can be addressed in that particular session, and using that Pendleton's feedback or the sandwich method, so that the students can take that feedback effectively. But one-to-one feedback may not be possible in UG.
Yes. Because of the increasing number of students, and in some colleges we have around 250 students, so where it is not practically doable. And the other question from Dr. Nishant Thakuria, that whether students should give the feedback of their teachers. Yes, it is very essential for us to know how we are performing. And I, in fact, take the students' feedback, and not on a very regular basis, but then occasionally I take their feedback and I ask them to give in writing without mentioning their name, roll number whatsoever. And I have a box where they can drop their feedbacks. And sometimes I feel good. It's not only on me, it's basically on my whole department, how my colleagues, how my other people are performing. So it is essential to know how we are performing, where we stand, how we can improvise. And feedback, I would like to end up by saying that feedback is a tool to improvise. So we have to take it with that positive attitude. And I think with this, we can end up this session if everyone permits. Thank you so much. Thank you, Dr. Sushil Sharma, and thank you everyone. I see almost 240 participants today attending, and this is something very awesome, wonderful, fantastic. And thank you everyone for joining us today. Thank you.
Thank you, sir. Thank you very much. And as the organizing secretary of the CBME Series 3 workshop, I thank each and every participant from the bottom of my heart who have registered for the workshop and taken out time and are with us today and also in the previous sessions. So that means a lot to us. And we will come back again very, very soon with the CBME Series 4 workshop or something else, but we will surely come back. And like I said in my earlier this thing, that WhatsApp group is active. It will be active for a few more days. And let's have some discussions. Any question and answer, those things will be tackled there. And in my presentation, I have purposefully only discussed the giving of effective feedback. And like, it is rightly mentioned by Dr. Pinaki Chakravarti, taking feedback is also absolutely crucial, but that is maybe for some other session. Today, we were just discussing about how to give effective feedback. So let us give feedback to our students. Let us tell them where they are doing well, where they're doing not so well, with the ultimate aim of improving them and making them better human beings. Thank you very much, and good afternoon, everyone.
Kamal sir will end the meeting.
Yeah, it was an awesome session, and so many participants have participated. And at the conclusion of this session, I would like to announce that all the certificates of all the participants shall be delivered within 20 days from now. And WhatsApp group will remain, as our organizing secretary have told. WhatsApp group will remain functional for 1 or 2 weeks. After that, we will be dissolving WhatsApp group. And any delegate who is having the query for anything, he can raise in the WhatsApp group, and all the resource faculty will try to give the answer in the WhatsApp group. thank you all for your participation, and thank you for your continuous support to the National Association of Pharmacology and Therapeutics. Jai Hind. Thank you all.
Thank you, sir.